I'd like to start our discussion about mood disorders by asking, why do we have them? Well, we have them because of the evolutionary process. These emotions helped us to survive and reproduce. Humans didn't live in isolation, but we lived in communities and tribes, and these emotions helped not only the individual, but the tribe as well. So for sadness, it's a response to defeat, and by getting sad, one starts avoiding future situations that would cause the same mistake twice. Motivates individuals to seek social support, which improves social cohesion and permits us in the group to withdraw from unsuccessful efforts and to use our resources where our efforts may bear fruit. On the other side, we've got joy and grandiosity, which is a response to success. When you feel joy, you're motivated to repeat that behavior that brought you success. Joy, grandiosity promote creative and goal-directed pursuits that both lead to social cohesion and lead to selective advantages. We need a few people in our group to have some risk-taking behavior. Risk can sometimes end up being catastrophes, but occasionally they can make a big impact in offering selective advantage to one group over another group. And as we'll see in patients who develop mania, that there is an increased sexual behavior that can lead to increased offspring. These are the major surveys looking at the lifetime prevalence of mood disorders. And I just want to take you to the one all the way to the right, which looks at the prevalence in the early 2000s. What you see here is the lifetime prevalence of major depressive disorder plus dysthymia, which is a chronic lower level of depression. Add these two up, 16.6 and 2.5, and you're talking nearly 20% of the population will have a depressive syndrome during the course of their lifetime. Now we look at the lifetime prevalence of bipolar disorder, and we see it's below 5%. So what does this tell us? It says that the natural selection process selected us to become a more depressive species than a happy species. The pessimists have won over the optimists. Harkening back to our lecture on the mental status exam, it's important to know the difference between mood and affect. For mood, we can use either the patient's stated mood, i.e. the patient says he is, quote, happy. We can also use the inferred mood as it appears to you, the examiner. So I might say the patient states he's, quote, happy, and he appears elevated mood to the examiner. Affect is more like the mechanics of mood, the range, the intensity, whether it's appropriate to content or congruent to stated mood. So here are some of the usual descriptors we use, important to understand them. Labile is when the mood is all over the place, crying 1 minute, irritable the next minute, laughing the next minute. Full range is what we consider normal. The mood fluctuates based upon what we're talking about. And restricted, blunted, and flat are progressively greater disturbance in which the person only has a narrow band of mood that they're expressing. Appropriate and inappropriate is used to refer to what the patient's content of what the patient's talking about, and congruent and incongruent are used to refer to the patient's stated mood. So does the mood that they state match the mood they express? So moods are normal things. So when do they become pathological? Well, when they are disproportionate to the stressor that began the depression. When they're prolonged duration, they last longer than what would be expected. When consolation and comfort or a good thing happens, nothing makes this person change. When the mood is pervasive and unrelenting, they can't be soothed, they can't go watch a movie and feel better, but they're constantly feeling depressed. And when there's impairment in judgment and behavior, a person who's depressed might injure himself. A person who's manic could injure others. So the DSM gives us these diagnostic criteria to delineate what's pathology versus what's a normal up and down. There are two disturbances, depression and mania, and that's what we're going to define in this lecture. Mood disorders involve different diseases that are characterized by depressive or manic episodes. So there's a difference between episodes and disorders, which I hope will become clear as we talk further. So this is the DSM-5 criteria for a major depressive episode. So you need 1 in the yellow and 4 of the rest for at least 2 weeks, most of the day of those 2 weeks. If you meet those criteria, you've got a major depressive episode. So let's just look at these a little more closely. So you have to have either depressed mood and or anhedonia, which is a decreased ability to experience pleasure. Then you can have weight gain or weight loss, along with increased appetite, decreased appetite. You can have insomnia or excessive somnolence. There can be agitation or retardation, meaning kind of withdrawal. Pervasive loss of fatigue, of energy or fatigue, worthlessness, guilt, impaired concentration, being unable to make decisions, and recurrent thoughts of death or suicide. So you just need 5 in total, 1 of which has to be in the yellow. These symptoms cannot be due to another medical condition such as hypothyroidism or a substance such as alcohol. These symptoms have to be significant enough to cause distress to the individual or impairment in their functioning. And they have to last 2 weeks, almost every day of those 2 weeks. So what about when a person has significant loss like bankruptcy, a failed marriage, the death of a loved one? Well, in many of those scenarios, you're going to have intense sadness. There'll be ruminations, there'll be sleep issues, appetite issues. Now, the DSM-5 is pretty clear in stating if you meet the criteria for a major depressive episode, it doesn't matter what prompted it. If you meet the criteria, then you're having a major depressive episode. Now, what to do about that major depressive episode can be watchful waiting, could be counseling, or could be medication. Studies have found that regardless of the cause, when a person meets the criteria of a major depressive episode, they can respond to treatment. And the real fear is that the physician will say, oh, I would feel like that if I were getting divorced too. And if the physician dismisses it as, quote, normal, then bad things can happen. For instance, a patient with depression could hurt themselves. So medical students like mnemonics, and in fact there are some mnemonics that have survived the ages, and the attendings are using these mnemonics. Well, the first one is sad A faces, and you see what each letter represents there. The far more common mnemonic is SIGI caps. It's so common that you'll look at a doctor's note and will say patient meets SIGI caps criteria, therefore they're having a major depressive episode. So what are SIGI caps? Disorder of sleep, interest, guilt, energy, concentration, appetite, motor agitation or retardation, suicidal ideation.
But there are other symptoms of depression. A person may describe frequent crying spells, feeling helpless or hopeless. Irritability and aggressiveness are particularly found in men who are depressed, but can also be found in women. 60% of people with a major depressive episode also have concomitant anxiety, which can be crippling. Somatic symptoms, well, we know fatigue and psychomotor retardation or agitation can be found in depression, but you also find symptoms of pain, alterations in bowel movements, any kind of GI upset or dyspepsia, joint pain, myalgias, etc. People with depression will also describe lack of sexual interest, or it can be even lack of arousal or inability to achieve orgasm. Some people with depression neglect their appearance, and they may look disheveled when they come into the office. And there are severe forms of major depression where a person will have hallucinations and or delusions, and we call that a psychotic depression. So one of the most common screening tools that are used in primary care is a tool called the PHQ-9, the Patient Health Questionnaire, PHQ-9. And you'll see this is administered to patients, and they then rate themselves according to all these criteria. And you basically have the 9 symptoms of depression, and as you look at the columns, the patient will say, well, several days in the past 2 weeks, more than half the days, and nearly every day. The more depressed they are, the more they're going to congregate towards the 2 and the 3s, and when you add them up, you actually get a number that can tell you how severe the depression is, and this can also be used to follow the patient's response to treatment. So a person gets a 5 to 9 as a score, it's mild symptoms. If it's 10 to 14, they have minor depression or a mild major depression. At which point you can think about psychotherapy or watchful waiting. But as the depression is more severe, you get these higher numbers, and intervention becomes more and more important, either with psychotherapy or medication or both. Okay, so now we're going to look at a case of major depressive episode.
Mrs. Houston, please tell me why you came to the hospital.
My marriage broke apart.
When was this?
My marriage? 6 months ago.
How long were you married? How'd the breakup affect you?
I moved to an apartment by myself in another town.
How's that done for you?
Terrible. I don't feel like meeting new people.
Meeting new people?
They're busy and want to do things. I don't feel like going out. I just want to stay close by.
Close by to?
Things in the apartment.
Tell me about something in your apartment.
Like what?
Anything. Describe one thing from your apartment. What's the first thing you think of?
My bed.
What do you call your husband?
Robert. He's never coming back. And my son, he left. He got a job in San Diego, 3,000 miles away. I can't afford to visit him.
How often do you see your son?
He lived with me until last week. But my worry about Robert drove him away. And my back pain. I tried not to complain, but
Mrs. Houston, what are you feeling now?
Empty. Lost. There's nothing left.
Have you thought about hurting yourself or taking your life? How would you do that?
Pills.
What about pills?
Sunday morning. I didn't go to church. I took all my pills. There was no way anything was going to change.
What happened?
My neighbor, Mrs. Laughlin, found me. We sit together at church. She came by the apartment to check on me and called an ambulance.
How'd you feel about that?
She should have let me die. Everyone would have been better off.
To whom do you feel you're a burden?
My son. My father, maybe.
Your father?
He worked so hard to give me a better life, and I threw it all away. I'm sorry. I'm sorry.
Tell me about your father.
When I was a little girl, he had a dream. When I was 4 or 5.
So let's describe the mental status exam of that woman who we just saw. Her appearance, her hair is slightly disheveled. She's not wearing makeup. You see some degree of self-neglect. Her attitude and behavior, well, she's cooperative, but she makes very poor eye contact. She's tearful. And you notice there's not much movement. She does have psychomotor retardation. Her speech is slow. There's even some latency of speech. There's a pause after the interviewer asks her some questions. She pauses for a while. We call that latency of speech. Well, her mood is clearly depressed, and she has a constricted affect, meaning her mood is at a very narrow band, and we would call that constricted. It's not flat. Flat would be no emotional expression at all, but she does have expression. It's just very restricted to the depressed range, and it's appropriate to the content. She talks about her husband having left her, and that would assumingly make many people sad and upset. Her thought process is linear. There is some thought blocking. There is a point in which the interviewer asks her a question, and she has a very prolonged pause and then says, "Can you ask that question again?" That's an example of thought blocking, losing the train of thought mid-sentence. Thought content. She's preoccupied with feelings of guilt, worthless, and she also has plenty of physical complaints. She does have suicidality with the idea to overdose, and she intended to overdose. In fact, she almost succeeded had her friend not knocked on the door at the time. She was not asked about homicidal ideation, hallucinations, or delusions, but she should be asked about those things. Remember, every time you describe thought content, you have to include suicidality, violence, hallucinations, and delusions. That must be always asked about and documented under thought content. Her insight is fair. She's certainly aware she's depressed, but her judgment is poor. Instead of seeking help and seeking treatment, she thinks about killing herself.